premise behind this is that you can put all the money you want in healthcare. You can get platinum level universal healthcare coverage and insurance. I actually see patients all the time who have that. They're called military eligible patients. They have access to any drug, any specialty, any lab test, any scan, any primary care group that you want. And it's totally capitated. They don't pay anything. And I can spend as much time with them as I want. And yet, that system does not get people better. It has not solved the problem of increasing costs, which are now through the roof, declining life expectancy, which is now through the floor. Almost 2 years in the last 2 years of dropped life expectancy, declined life expectancy, 3 to 4 times that in people of color. Disparities getting wider. Dissatisfaction among the patients getting greater, and burnout among clinicians also increasing. So just about any metric that you use in healthcare, we're going the wrong way. And the reason for that is that healthcare does not provide health. Healthcare, if we were to have the platinum level healthcare like my patients have for the entire country, it's now well documented that you would increase the health of the population by about 15 to 20%. If you want to look at that, look at the University of Wisconsin County Health Metrics. They track this every single year. What are the determinants of health, and where does health actually come from? And healthcare, actual healthcare, medical care coverage is about 15%. And that's because health actually comes from behavior and lifestyle, and or social and economic conditions that don't allow you to engage in the behavior. Okay, and so if we don't in healthcare get out of the medical care and treatment delivery business, we are not going to produce health, and we are going to continue to do what Warren Buffett said healthcare was many years ago, which is a tapeworm of society, sucking the resources out of all the other things that we want, such as education, even defense, et cetera, et cetera. And we're now even doing that even more. And so to do that, we have to redesign how healthcare gets delivered. And that for some people that can afford it, you can do fancy technology-based concierge type medicine, and provide them with the time, the effort, the health promotion component with that. But for the vast majority of the population, and we've seen examples of people doing it here. So a lot of the innovators here are a bit of an exception. They're a lot of an exception. That's why they're here at the innovators meeting. Don't step out of the box there. And so here's what I just said. Okay, our current model of healthcare doesn't work. It's not meeting the national goals. A whole person care, which is a redesigned healthcare delivery system, is what's needed. That is something that takes care of the social and emotional factors, the mental and spiritual components, the behavioral and lifestyle components, and the economic aspects of it. COVID has accelerated both the problem and a readiness to actually do something more than just incremental, but to do something that we keep saying is transformative. Okay? But what does that actually look like? Our hypothesis is that paying for whole person care would catalyze healthcare systems and innovations like you've seen here to grow and spread. There's a lot of ways to do it, but yeah, there's some core elements that have to be there. And so this was some recommendations we made to the White House, and I'll show you, kind of drill down on specific things that we thought that they could actually do. Okay, so this is everything I just shows that how healthcare is not working. That's the drop in life expectancy. Here's some of the effects of COVID across the system. Primary care physicians are struggling, especially in rural and underserved areas, although large hospital systems seem to be doing quite well. There are increasing mental health problems among providers and families in those areas. It's manifest especially in young people. We've heard a lot about that, but it's occurred more than that. Opioid epidemic that was occurring before the pandemic came along didn't go away. In fact, it's now worse. We had 60,000 or so deaths from opioid overdose prior to the pandemic. We now have in the neighborhood of 100,000 a year. And healthcare executives have decided, boy, I have to respond to this during this time. And so a lot of the process improvement and innovation models that we're going to just put on hold. Just like care was put on hold. A lot of patients just stopped going in, and we're going to see the manifestations of that in cancer and various other conditions, and are seeing that already. And this is why it's not working, because what we do right now is in that top box, and that isn't going to fix it. Okay, next slide. So I wrote this article in the Journal of Family Practice to try to illustrate where the term integrative health and where the factors that are normally talked about as integrative health, these are non-pharmacological and behavioral lifestyle-based approaches fit in advanced primary care model and where the social determinants fit. And so if you look at this target right in the middle is sort of the standard treat and treat, okay? I give you the diagnosis, you give me the code, then I get it paid for. And that's standard care. The Starfield model is the second ring there, comprehensive, coordinated, continuous care. That's quality primary care, no question about it, if people were doing that, but it's not enough because it doesn't really coordinate and add in explicitly mental health, chronic care management, pharmacy management, and referral and transition components of it in an effective way. So if you added those things to it, and we saw some examples, Adelaide is helping people do that, Catalyst is another group that Larry's had here before, big network in Texas that assists that, other people are doing that. Now you get to enhanced primary care, okay? You gotta build on those things. And what I call advanced primary care has to add to that those underlying determinants of health, behavioral and lifestyle on one side, and the social determinants on the other side in those areas. So that's a lot of circles there, okay, in those areas. And what I refer to as integrative health is just this left side there. That's a component. Sometimes lifestyle medicine is part of that, non-pharmacological approaches are part of that, and then of course the social determinants. Next slide. So a lot of this stuff was embedded in this report. I mean, in my opinion, they did a great job of languaging and laying out very, very complex things in fairly simple ways. I've sat on a number of these kinds of commissions before, and the biggest problem is that you've got 1,700 recommendations, and then if you get them down to 700, you're doing okay. And they actually got them down to about 7, I think, which really got at the core issues that need to be done. So I thought it was extremely good. I especially liked it because they started using the terms and the concepts of whole person care and of integrated, accessible, and equitable care in those areas. And they chalked it. This is the definition that they used at the beginning, and they chalked the rest of the report with that framework through the effort. What they didn't do is that they didn't do what I'll show you that I think is an essential component we've been talking about all day, which is value-based care. They talked about hybrid-based models. And I'm not sure if you can do a hybrid whole person care. Does that mean you take care of the top half of the body, if it's half, or the bottom half, or left or the right half, or whatever? Next slide, please. So then Biden came along, and he's doing a little better now, but at the time he gave the State of the Union address, man, didn't look like he was going to get anything done, okay? And so what he tried to do at the end of the State of the Union speech is say, well, I know there are 4 bipartisan things that we can all agree on, okay? And these were the 4. Take a look at them, okay? Beat the opioid epidemic, improve mental health in the nation, support our veterans' health, okay? And reduce cancer. Every single one of those is a healthcare issue, okay? So out of global warming, about everything else that could be education, everything else, the pandemic at the time was still raging. He comes up with the 4 unity agendas, which are all healthcare. So we wrote to him and said, hey, if you address the social determinants and you have a model that pays for that, and the personal determinants, that is the behavioral components, and that tap into the inherent healing capacities of an individual. You can solve all four of those problems at the same time, okay? And if you try to pick them off one at a time, you're probably not going to do much. So anyway, these are the things we suggested to them. Next slide, please. Here's why we think transformation is possible. ACA is actually already established, and we now see community care organizations. There's an infrastructure around doing this. The data's there, both pre and post-COVID, the need to do that. We've got plenty of data to show what needs to be done. There's a lot of new major networks and innovations actually popping up because they see the writing on the wall, they see the money coming down, and there are dozens and dozens of groups, from technology companies to food delivery companies to book delivery companies. There's this little one called Amazon, to retail groups like Walmart and things like that. CVS already jumped into this years ago, that are coming for primary care. They're coming for the money, and they are providing services at lower cost, right? Convenient access to services at lower cost. Private payers are looking for leadership in those areas. We just talked about the need for purchasers, okay? Corporate purchasers, companies, self-insured companies, they need some leadership and some help in those areas. So there's a lot of pent-up desire for this kind of transformation. Next slide, please. I wrote this with Brian Attaby and published it in JAMA Health Forum as a framework for the core principles that all of these approaches could use. And different models, there's different ways that they apply it, but these are the elements that need to be in there. Person-centered, so that means it's no longer about a patient, because we're no longer talking about just the treat and treat, right? We're talking about their life. And not just their lifestyle, their life. What's meaningful and purposeful in their life, okay? What brings them joy and happiness? Why do they even want to have health? Because they have to be engaged in the actual process of health creation. So that's person-centered care. Relationship-based, there's going to be a battle over transaction versus relationship-based. You're going to see it pan out in the recent purchase of Amazon purchase of, was it One Health first time?
Medical.
One Medical, which purchased a far left relationship-based system called Iora. I'd love to see that battle. Hopefully we can have Rushika here and talk about how that's going on. But that is a cultural clash right there, okay? But relationship-based care, well established. I mean, if you look at the top performing primary care groups around the country, public health groups around the country, Stanford has done these studies, many others, Peterson Group did these studies. Relationships has been at the center of that. How do you do that? Recovery focused, it's not just treated after it happens, it has to be about getting better. And I think the military is actually one, and the VA more, but the military is a great example of that. They stand up these centers that are about recovery, okay? And they throw intensive behavioral and other kinds of integrative approaches, and they actually demonstrate clear recovery. We're not talking about just treating your blood pressure for the rest of your life. We're talking about curing it, okay? And we saw an example of that earlier today. So all that can't happen unless you pay for health instead of health care in those areas. And this means that the medical services that ask what's the matter, make the diagnosis, and provide that using tools like the SOAP note, need to be integrated with what matters to the person, okay? The personal determinants of health, recovery services, which are the social support, the lifestyle, the mental health, etc. I've proposed a new tool, because we can't use the same tool. This tool doesn't work for that. The Hope Note, and they need to be integrated into this relationship-based values. So that's it. So anyway, those are the core parameters of the model right there. Next slide. Unleash whole person care. I think we could do it, because there's all this pent-up energy to do this. There's innovators out there doing it. They're trying to do it, etc. But we have to pay for it. We have to define value, and value can't be defined on a process of quality. We can't use quality metrics that are about process. They have to be outcome. in those areas. We know what those are. They're the quintuple aim divided by the cost per person. That equals value. We need to take the handcuffs off the healthcare team. We can't say, oh, good, we'll pay you for taking care of people. Oh, but you can't do that. Okay? That doesn't work, okay? Because now you're handcuffing the actual delivery team. Healthcare systems have to be accountable. You've got a lot of people out there just going after the money. I've mentioned a few of them probably in those areas. And so you have to have accountability. But the accountability has to be the value-based components. They have to be on the outcomes, not the output process in those areas. And the quintuple aim is now, I think, the only framework we could really use for this. Next slide, please. Okay, so this went into the blueprint. You know, there's a blueprint that's about to come out after the report. OASH is working hard at it. And in addition to those principles that I just mentioned on that side, I said, here's the core recommendations of the National Academies report here. Okay, definitely do that. They talk about training and education in the community that's necessary. They talk about a redesign of technology. I don't think we're going to be able to slap another act on our current healthcare system. I mean, again, you can go look at a system like IORA, you can look at a system like ChenMed that has been here. They could not use current technology to actually deliver person-centered care. They had to build their own. And anyway, I just don't think you're going to find an integrator on the technology space that's going to solve all those problems. And then ensure that it's implemented in the United States. That's sort of, okay, great. I'll figure out how to do that. All right, next slide here. So we proposed an immediate thing that the administration could do, because remember when we are in discussions, we're still in discussions with them, but this was right after the State of the Union address, and it didn't look like there was going to be any cooperation on the congressional side for any of these reforms. So what could the administration do? And these are some things that they could do because they already exist. Expand Section 1115 demonstration projects, and take immediate action to reduce administrative burden, that's taking the handcuffs off. Create 100 equity enhancement sites. I would say more than that. That was sort of a modest thing. And these were sites in which they're paid to deliver on the quintuple aim. Okay? And the cost of that, we have a pretty good idea of what it is. It's about $10,000 to $15,000 per patient, risk adjusted, mostly socially risk adjusted. Okay, per person per year. Take the people that are working in safety net hospitals or FQHCs, and instead of giving it to the health, giving your rescue, your COVID rescue money to the system, and then telling them to hold their employees and keep doing the work, give it directly to the providers. Okay, pay them. Okay? Give them money. All right, give their systems money. Give them a bonus, and provide immediate support for primary care transformation. Here's one example. Okay, so I think that is my last slide. Next one. Yeah. And so now my friend Alan's going to take over and tell you how this is happening up at Jamaica.
So I will try to be brief. I know it's late on the time and other people are presenting, but essentially what I really tried to do, along with Dr. Jonas and Scott Conard, which we talked about this morning, of combining Dr. Jonas's advanced primary care model and integrative health together, and Converging Health was able to get us the technology that we needed to start to implement these plans. So as I mentioned earlier, we're a very underserved inner city hospital relying on public pay, so similar kind of to the VA. The way our system is set up, we're in our clinics, we're 90% globally capitated in how we care for the patients. We lose tons of money. We're a safety net hospital, and the way it is in New York, because we lose so much money, the state makes up the differences for the cost that it takes us to give care. So our goal is and remains, and I'd say we're 25% into this, where we want to be, of implementing the two circle whole person health model, using the quintuple aim in addressing the needs of our patients and their families. we put together a kind of 4-phase program looking at initiating this. Phase 1 was various educational things. We started with help from Dr. Jonas and his foundation. We implemented in our Epic EHR the Hope Note. We've done over 1,500 Hope Notes now, but we're incorporating integrative approaches in pretty much everything we do. We became part of the Family Medicine Education Consortium's Learning Collaborative. We're working with Dr. Jeff Geller. If people don't know Jeff, Jeff is a guru with group visits, and we're trying to do a lot of what we do through group-related visits that are empowerment groups, wellness and health. Some of it is disease-specific, but much more general. We got administration buy-in, so this is coming from the top down, where our senior administration is bought into the fact that we're going to continue to lose tons of money unless we help keep our patients healthy. It's the only way that we're going to survive, and as we've shown, we only make a 10 or 15% difference in the healthcare we do, so we have to change the way we do it through education and work to make our folks healthy. So we've started it, implementing it in various ways. We have some success in 2 areas so far. We've implemented an integrative approach in our subacute nursing facility. So patients who are admitted to our nursing facility are allowed to join in our integrative health program. We offer services every day in 2-week blocks, because most of the people are there for about 4 to 6 weeks. So they get a 2-week curriculum of nutrition, exercise, massage therapy, acupuncture, Reiki healing, and all of this is done through volunteer work of some of our faculty who have expertise in these areas. The other area which we're pretty well implemented in, or working on implementing, is we have a tremendous amount of gun violence in our community. A lot of what we're trying to do is decrease the incidence of this in our communities by working with survivors, families, perpetrators of the crime, and have created a center where we're giving holistic, integrative, whole person health care to both the victims and perpetrators of some of this violent crime. We were fortunate enough to get a small grant from the mayor's office. There's a lot of money in gun violence prevention right now. We are about to, phase 3, implement some of these in 3 of our sites. We have like 12 sites. We're doing it in 3, where I have 2 providers in each of those sites that are either integrative fellowship trained or University of Arizona trained. So we have a reasonable amount of internal expertise with providers. So currently I have 6 providers in our network, so 2 in each of those 3 sites. We're going to form, or we are forming, what we're calling integrative practice units. So within our regular office-based setting, we're providing with those sets of doctors a more integrative approach to care. And we're looking to kind of study the 2 sets of folks of, are we able to, in an urban inner city setting, show that this approach to care is cost effective and improves the patient's quality of life. We're using patient navigators now. We hope to train more health advocates, health coach kind of folks that will have more of a knowledge of the integrative approach to care regarding prevention and wellness and keeping people good. There's a bunch of modalities that we have. Most of them are through the 6 providers that we have, but since we don't have a lot of resources, we're fortunate enough that we were able to sign a contract with a massage therapy school, and in January we're going to be able to offer massage therapy to our patients for free of charge, as well as an acupuncture school. The other modalities we're doing internally, but those 2 modalities we kind of were fortunate enough to have students come in under supervision delivering the care. As I mentioned, the group visits are a huge component of what we're doing. It's very cost effective and the patients are really enjoying it. I think it's a very efficient way to care for patients in our centers. As Dr. Jonas said, it's recovery focused, introductory group visits. We are using the Hope Note tools on our patients. And we're asking the patients that are joining, they have to kind of sign in. It's not a contract or anything, but patients want to have a understanding through this introductory group visit that they're entering an integrative, holistic, patient-centered, relationship-focused goal to care. And then the last thing we are trying to do is open an urban integrative center within our community. We're looking for sites. We thought we had funding actually to buy something. It unfortunately fell through because we're too poor for anyone to want to lend us money, even people who want to lend poor people money, so it fell through. So we have a couple of sites in mind, and we're hopeful that this time next year we'll have a site to begin. So within the site, we're really looking to provide comprehensive services of wellness and health, so to have a gym for the folks and teach them how to utilize, exercise well. We're looking to have a cooking kitchen and a greengrocer within the facility to offer, a more modern, comprehensive approach to care. So we think we've been pretty successful so far for the fact that we have no money and we can't pay for any of this stuff. But fortunately, my administration believes in us and believes in what we're doing and believes the fact that they see it, that if we can keep people healthy, we're going to save the system money. So that's it.
Yeah.
We'll take a couple questions or
Yeah,
reactions.
Yeah, just a quick one. First of all, I love the asset-based approach you're using here. Can you connect the dots between that great graphic there and what you're doing?
So that's what we're trying to do. So fortunately, Dr. Jonas and Dr. Connor know each other, and so the metrics that we're following and the data that we're getting here is pulling out metrics like we're trying to use to implement the integrative approach to care and identify the patients that we think would best fit this therapy.
In the sweet spot.
In the sweet spot
Yeah.
of the right lower quadrant.
Yeah.
So we're actively looking for those patients
Right.
to do a better job in a whole person approach to their care.
Great, thank you.
Okay, thank you.
Okay,
Thanks.